So I will go ahead. I believe that you are seeing my screen, so hopefully this is working. But, I've been asked to take on really what I'd say is the million-dollar question these days in diffuse large B-cell lymphoma, and that is, how do we sequence all of these novel approaches that are coming through the pipeline? And I don't pretend to have the answers, but I will talk a little bit about what the options are and how I think through the problem at this point in time till we have more data. So these are my disclosures. So diffuse large B-cell lymphoma is one of those sort of good to have problems in that we do have a lot of treatment options available for these patients. In the frontline setting, R-CHOP has been the standard of care, although HOLA-R-CHP may be moving in as another standard of care option shortly. But with R-CHOP across a population of patients, what we're able to see is that we can cure the majority of patients, but the real difficulties lie with the patients who, unfortunately, despite our best attempt, are unable to be cured. Most of them declare themselves fairly early with relapse within the first 2 years. The other important thing I'd point out is that if you look at these outcome curves, despite our best abilities, the majority of patients, unfortunately, if they relapse after frontline therapy, will succumb to their disease because we have been salvaging relatively few patients in the secondary setting. So we've got two problems going on. How do we make frontline therapy better so that relapse refractory disease doesn't have to be a problem? But in patients with relapse refractory disease, unfortunately, across a population of patients, I'd say that, historically patients have done relatively poorly. The ingrained management strategy that we've had for decades has really relied on trying to get patients the transplant in the second line setting if they've relapsed as really the primary way that we have to potentially cure these patients. Unfortunately, only about half of those patients would be eligible for transplant based on age and comorbidities. They would then need to go down the route of salvage therapy, and in order to go to transplant, they'd have to prove to be responsive to salvage, and only about half of those patients would be. And even those patients that went on to transplant, the majority of them would relapse. So despite trying to take people down the left side of this slide with a curative approach of stem cell transplant, in the end, the reality is that 90% of people would fall into this box, which is, what we would now term as transplant ineligible patients. The good news is that our options in this box are increasing, and I think it's fair to say that not only increasing, but offering patients new curative options. But historically, before we had the novel therapies, my main options in my own clinic would be to rely on palliative single agent or multi-agent chemotherapy, occasionally palliative radiation therapy, but that, of course, is a local maneuver. We rarely use allogeneic transplant in this population, although obviously there's some reports that it can be curative for some patients. I think in general, it's not very feasible in that these patients are often older, they have rapidly progressive disease, and it doesn't, provide an amenable opportunity to get the transplant organized. CAR T-cell therapy, which I'll talk about in a minute, has been really transformative for relapsed refractory DLBCL. And of course, then we've got a slew of novel agents. So briefly on CAR T-cell therapy, we know that there are 3 anti-CD19 CAR T-cell therapies that have made their way into the market. This was all based on really single-arm data from pivotal trials in the third line plus setting. Now, I have to say that I was a bit of a skeptic in that while we recognize that this was a clear demonstration of the power of immunotherapy for DLBCL, relying on the data from these pivotal trials, my concern was initially that this was highly selected patients and that, with longer follow-up, we couldn't be certain that these patients were going to be cured or where these curves would settle out. This is just a compiled table from a recent review article from Blood that looked at the most recent data from these pivotal trials. And you can see now that follow-up is fairly mature from some of the trials. So we've got about 5 years of follow-up now from Zuma and 40 months from the Juliet trial. And with the long follow-up, we're still seeing that there are patients that have achieved durable control, and that is about 35 to 40% of patients entered in these pivotal trials. So I think it's time that we can start using the word cure with CAR T-cell therapy, which now, really opens up, I think, the fact that in the similar way where we used to try to get patients to stem cell transplant as a priority, we now need to figure out how to get patients to CAR T cells as a priority and where this should fit in. In addition to the longer follow-up from the pivotal trial, I'm also encouraged by the fact that there is more and more data emerging from real-world settings. So speaking to that concept that the pivotal trials probably had very selected patients, we're now seeing large registry data being reviewed. I really like this paper from the CIBMTR, which was just recently published, and it looked at essentially over 1,200 patients who had been treated with CAR T-cell therapy, and they divided patients based on clinical characteristics to those who would have been eligible for the Zuma 1 trial and those who would not have been eligible because of various patient eligibility constraints. And what they really showed was that outcomes were comparable and that patients who fit outside of the box of what was entered into the pivotal trials can actually do quite comparably. And again, we're seeing very durable remissions for some of these patients. So more, I guess, proof that you can roll this treatment out into a more real-world setting and see very good outcomes. Although I would point you to probably taking a look at the details of this paper, because it was striking when they compared the toxicity from those who are eligible for the trial and those who would not have been eligible for the trial. There is a step up in toxicity when we roll this up into a broader population. So understanding that CAR T-cell therapy may in fact be curable now for some patients with relapsed refractory DLBCL, obviously the logical question is to ask, can this replace stem cell transplant in a proportion of patients that we're currently taking to stem cell transplant? Now, this is, I think, a topic of a separate talk in this meeting, so I'm only going to briefly discuss it to tell you where I think it fits in. But we must, keep in mind that patients who are intended for transplant, not all of them have the same prognosis. And one of the most powerful prognostic indicators is timing to relapse. So this is data from British Columbia that was recently presented at the last ASH meeting, looking at all of our patients who are technically transplant eligible and looking at their outcomes based on timing of relapse. And you can see that for those patients who relapse more than 24 months out from initial diagnosis, they can actually do very well with transplant with progression-free survivals of over 50%. But this group of patients who relapse early from the time of diagnosis, so 12 months or less, you can see that they are down well below the 20% range with transplant. So you're all undoubtedly familiar with the fact that there have been 3 randomized trials performed in the second-line setting, pitting 2 different strategies against each other. So our standard approach of trying to go down the salvage and transplant route versus immediate CAR T-cell therapy in the highest risk patients of relapsed refractory DLBCL. And those are patients who either have primary refractory disease or progress within 12 months of therapy. This table summarizes the data from those 3 trials. There were some differences in the design of the trial. So Zuma 7 didn't allow bridging, Transform and Belinda did. you can see that in Transform and Belinda that allowed bridging, 60 to 80% of patients actually received it, so probably more of a real world population. Almost all of the patients intended for CAR T did receive it, so there was no sort of stopping point where people didn't go on to CAR T as long as the product was available. And it's interesting to see that, only a minority of patients were able to receive the stem cell transplant, which was not surprising because we know that many of the patients are going to not respond to salvage. And an important distinction also between the trials was there were some caveats in the Belinda trial where you had to have 2 lines of salvage before you could go on to CAR T, and there was a delay in receiving the T-cell product in that trial. So ultimately, both ZUMA-7 and Transform were positive trials for event-free survival, but no difference in overall survival at the time of initial evaluation, and Belinda was negative. I think taking the data in compilation and understanding the caveats of the Belinda trial, I think this is really compelling evidence that side by side, the two strategies really point to CAR T-cell being the better strategy in this high-risk patient group if it can be accessed. So I do believe that the algorithm should change for relapsed refractory DLBCL based on this data, and that we're no longer first asking the question, is the patient transplant eligible or not? The real first question is, what was the timing from initial therapy? And if it's less than a year, then CAR T-cell approach would be preferred. Otherwise, a transplant approach would be the default. Another important data set, though, I think that's important to highlight is that we know that some patients are eligible for CAR T who wouldn't have been eligible for stem cell transplant. And with the 3 randomized trials in the second-line setting, this group would not have been included in those randomized trials because they would have been transplant eligible. But knowing that CAR T-cell therapy is potentially curative, it seems almost artificial to hold it back to third-line setting for patients who would be CAR T eligible, but perhaps not transplant eligible. And there was recent pivotal data of lisocabtagene in this setting, using it as second-line therapy in patients who would not have been intended for transplant, showing efficacy and safety. And this data was actually used by the FDA to expand the indication label for lisocabtagene. So the indication by the FDA now for liso-cel includes not only the transplant eligible high-risk patients, but the ineligible patients in second-line setting. So I do think that should change the algorithm. So beyond CAR T-cell therapy, and we all know that I'm touting the merits of CAR T because I think it is transformative and does open a new curative option. But we do know that there are huge access issues in many countries and not everybody has access to it. We also know that despite availability to CAR T-cell therapy, not everybody is going to be able to get it because many patients have disease that is out of control and can't be contained for them to go on to CAR T. And despite receiving CAR T, the reality is still at this point in time, the majority of patients will relapse after CAR T, leaving open a very big need for additional novel therapies. The good news is that we do have a growing list of novel therapies now available for transplant ineligible patients and potentially CAR T-cell ineligible or post-CAR T-cell patients. I've listed the 4 options here, and I'm sure that what you're expecting me to do today is to tell you which ones to use in which order, but the reality is that none of these options have been compared against each other. So really what we're left with doing is interpreting, I would say, individual efficacy of each approach and matching it with the toxicity of that approach and then selecting it on a patient-by-patient basis, understanding who the patient might be. We also understand that, unfortunately, there are access issues, and not all of these options might be available in every country or for every patient. So starting first with polatuzumab vedotin, this is a drug you're undoubtedly familiar with. It is an antibody drug conjugate targeting CD79B, which is universally present on diffuse large B-cell lymphoma. It carries a powerful toxin called MMAE, which is the same toxin used in brentuximab vedotin, and it's a powerful microtubule disruptor that leads to cellular apoptosis. So the pivotal trial that earned approval in the relapse refractory setting was a phase 1b/2 study in which it was combined with bendamustine and rituximab. In the randomized phase 2 portion, it was compared with BR alone, and then there was an extension cohort looking at more longer-term safety and efficacy. This was done in a transplant ineligible patient from second line and beyond. So this is the compiled data, which includes long-term follow-up of the randomized phase 2 portion, as well as additional data from the extension cohort of over 100 more patients treated with Pola-BR. And you can see from the left side of the slide that with longer follow-up now being more than 4 years of follow-up, the benefit of Pola-BR over BR has remained consistent in that it led to improved progression-free and overall survival, with the median overall survival being 12.4 months. And if we look at the extension cohorts, although the follow-up here is shorter, the outcome is fairly comparable with median overall survival of 12.5 months. Thinking about what patients might preferentially benefit, so this trial included patients from second line and beyond, but there are some differences. So clearly, patients in the second line setting appear to do better than patients in the third line setting, which maybe is not too surprising. I'd say that's probably true for every treatment option that we have. Also, patients who have non-refractory or non-primary refractory disease tend to do better. But nonetheless, there is efficacy in patients with primary refractory disease. Regarding toxicity, the primary toxicities are hematologic with neutropenia, although the risk of infection is relatively low. And then, of course, we need to keep in mind peripheral neuropathy, which was largely low grade in this study because the treatment is capped at 6 cycles of therapy. So in the end, it's a finite therapy with, I would say, modest toxicities. Tafasitamab lenalidomide, I think, is probably also a treatment option that's becoming very desirable in the relapse refractory setting. This is really a combined immunotherapy approach of tafasitamab, which is an anti-CD19 monoclonal antibody, combined with the immunomodulatory drug lenalidomide. The pivotal trial that earned its approval was really just a single-arm trial looking at transplant-ineligible relapsed refractory disease. Keep in mind that this trial largely excluded primary refractory patients. So it was a better cohort of patients that was included. So again, hard to make cross-trial comparisons. It's a bit of an effortful regimen, so patients need to get weekly treatment of the tafasitamab for 3 months, and then every 2 weeks for the rest of the year, and then go on to get continuous therapy. Lenalidomide is given for an entire year. But the outcome was certainly encouraging, with very high overall response rates of 60% and CR rates of 43%, and median progression-free survival of 11 months. The patients who did the best were those patients who achieved a CR with a fairly impressive curve here that you can see out to up to 4 years, and still many patients maintaining durable benefit. So I think the signals of benefit here are very intriguing, although keeping in mind it was largely a relapse population. Regarding the safety, Probably most of the toxicities come from the first year and the lenalidomide use, because when you get beyond the first year and it's only the tafasitamab, you can see here that it's really low-grade minor toxicities. And the types of toxicities seen in the first year are largely what we anticipate attributable to lenalidomide. I'm going to briefly mention selinexor. This is not a drug that is approved in my own clinic, so I haven't had much experience with it. I would consider it to be a more modest drug in this setting, but it's an XPO inhibitor blocking export from the nucleus, leading to the buildup of tumor suppressors and apoptosis. It was approved based on a single-arm study done in transplant-ineligible relapsed refractory DLBCL. Again, I feel that there was some patient selection in this trial and that there was a large washout of really 2 to more than 3 months required on this trial. So patients with super progressive disease who need to go on to next line therapy probably would not have been eligible for this trial, but it is an oral therapy, so easy to administer twice weekly and is aimed to be given indefinitely. Modest results, though, across this population of patients. Response rates under 30%, CR rates only in the range of 10%, with a relatively low median progression-free survival. In terms of adverse events, I'd say this drug does come with a fair bit of constitutional side effects that can potentially affect patients' quality of life. So there's a lot of supportive care involved in managing patients on this drug. And, in a drug that's meant to be given indefinitely, I think there are some concerns about patient tolerance. Finally, the last approved drug I'll mention is loncastuximab tesirine. This is a antibody drug conjugate that is targeting CD19. This has a PBD dimer toxin that intercalates with DNA. This drug was approved based on single-arm data. Again, relapsed refractory DLBCL. Here it was enrolling patients who had received at least 2 lines of prior therapy, so probably a more highly pretreated population than the tafasitamab trial and the POLA trial. It's given initially as an IV infusion every 3 weeks for the first year, and then every 12 weeks subsequently, again intended to be given indefinitely. I would say, quite encouraging results as a single agent in this setting of patients. So overall response rates just under 50%, and half of those being CRs with progression-free survival in the range of 5 months. And it seems to be, although I haven't had access to it here in Canada, relatively tolerable, with the main toxicities being cytopenias and some transient transaminitis. So I think there may be a role for a drug like this, particularly for patients, with poor treatment tolerance or more frail patients, but it may be a drug that is also helpful in combination therapy. So it'll be interesting to see some of the ongoing studies. Finally, in closing, I'm just going to mention the bispecific antibodies. So we've been talking about bispecific antibodies for DLBCL for quite some time now, and it's fair to say that they're going to be coming to a clinic near us, hopefully soon. So the bispecific antibodies that have been furthest along in development have targeted CD20 and CD3 with the aim of bringing the T cells in proximity with the B cells to induce recognition and an immune therapy approach. Recently, we've seen pivotal results presented from several trials. So the pivotal results from glofitamab were presented last year at ASCO, and this was a trial that included a wide range of relapsed refractory aggressive B-cell lymphoma patients. This drug is given every 3 weeks after an initial loading period in the first cycle for a maximum of 12 months of therapy, so it is finite. And the pivotal results were highly encouraging, with response rates just in the range of about 50% and almost 40% of those being complete remissions. Follow-up is still a little bit short, but the median progression-free survival is 12.6 months, and you can see that there are a fair number of patients out beyond a year, certainly, that still are progression-free. Regarding the tolerance to treatment, having had experience with bispecifics, I would say that they are remarkably tolerable. Most of the toxicity stems from the initial cycle where CRS is a risk, although it's generally low grade and very manageable. Beyond that, it is cytopenias, but again, I would say that from a patient tolerance standpoint, they're actually very well tolerated. Additionally, this year we saw the pivotal data of subcutaneous epcoritamab presented. This was presented in the plenary session at the EHA meeting. In this study, it's a little bit more effortful, so it enrolled patients with relapsed refractory large B-cell lymphoma who had received at least 2 prior lines of therapy. Patients do need to get weekly treatment for the first 3 months and then go on to biweekly treatment and eventually switched over to monthly treatment. So it's a little bit more effortful than glofitamab, but again, a really remarkable waterfall plot with overall response rates over 60%, CR rates of just about 40%. And again, it's this early data where, it'll be important to see longer follow-up, but we can see here that over the 12-month mark, we're seeing some durable remissions, particularly in those patients who achieved a CR. So really, to summarize, I think it's such an exciting time right now that we're seeing novel agents emerging into the clinics that have the capacity to overcome chemotherapy resistance and even CAR T-cell resistance and stem cell transplant resistance, since many of the patients enrolled have had those prior therapies. In the second line setting, I would say that CAR T-cell therapy approach should replace stem cell transplant for early relapsing refractory patients or those patients who are not transplant eligible. Beyond that, sequencing some of the novel therapies that emerge, I think right now we're going to need to rely on what the goals of therapy might be in an individual patient, and then using the data to compare, what we know about efficacy and toxicity, convenience, patient preferences to select which agents to use in which orders. But of course, ideally, what we're really hoping that the field will move to is inevitably identification of predictive biomarkers that will certainly be essential to allow us to adopt a more patient-tailored approach and to know how to match which drug to which patient and at which time. So with that, I'll end there, and I'd be happy to answer any questions that you might have.